In this episode, we continue our discussion with Leslie Simmons, a registered nurse and fellow in the American College of Healthcare Executives. Leslie is Executive Vice President and Chief Operating Officer at LifeBridge Health. In addition to her system leadership roles, Leslie is also currently serving as Interim President of Sinai Hospital and Grace Medical Center. As we continue our discussion, this episode focuses in on her current perspectives as System COO. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Leslie, welcome back. We're continuing our discussion from a previous episode where you shared your leadership journey as well as your perspective on the essentials of a nurse executive transitioning from a hospital leadership role to a system leadership role. So in your current system leadership role, what's keeping you up at night right now?
Yeah, so without a doubt, it is employee engagement and staffing. Listen, as a nurse, I'm honestly really bothered by the impact of the pandemic. None of us have ever experienced anything like COVID. It was the most prolonged healthcare crisis that we've had. And frankly, it hasn't necessarily even been declared over yet. And so some of us are forcing the issue and we're loosening our masking requirements a little bit and trying to claw our way back to some sense of normalcy and really doing that without a playbook. But we're talking 3 years. And I can tell you, there are still nurses that are like, is there going to be another surge? And are we going to survive that? That was horrible when we went through that. I look at some of the eyes of our healthcare workers and some of some of the excitement or some of the luster is gone from their eyes. I feel like they're going through the motions. I feel like they're really exhausted. And I feel in healthcare, we tend to say, whew, that big flu season's behind us. Whew, glad that's over with. Or that COVID surge is over. Glad that's over with. And then we just push ahead. But we never take a moment and acknowledge the quote moral injury, the injury that just happened to us as surviving this. The amount of death that we all saw and the sense of hopelessness that we had at the beginning of the pandemic. Nick, I remember being on a conference call with my colleagues from Johns Hopkins University. How do we treat this? And I'm serious when I tell you, some of those highly regarded experts, we don't know. We're not really sure. We're trying this and this. What? What do you mean? Our own relatives were dying in front of us, and then we're in isolation and we can't see them and we don't know what to do. That's a scary time. And we just pushed through. We did what we had to do. But now I don't think that we've taken enough time to acknowledge that, to debrief from that. My goodness, we debrief when there's a code green, a combative patient, and say, how could we have done that better? Some of us have done a little bit of what we call a debriefing from the emergency response. But have we really debriefed our staff from a sense of PTSD? So honestly, I don't want to get on that soapbox, but that's what worries me. I'm trying to reignite the desire, reignite the passion for healthcare, remind them of their purpose. Working remotely, help people learn there are other choices. I can't tell you the amount of nurses that we've lost because they're just so fatigued. They're just done. especially critical care, ER, my specialties that I love. They're just exhausted. Respiratory therapists, I'm done. It's just the effect on our workforce is, I believe we're going to see ripple effects from this for years and years to come. I really do. So that worries me. What motivates me is trying to create an environment where they get excited again and they can feel great about what they're doing. They feel supported. They feel like they have the tools they need to do their job. They feel like they're being heard and seen. I see you. I see what you're doing. I can't emphasize that enough. But that's the kind of stuff that worries me. What is that pipeline? How do we reignite the passion? That's the worry for me. I want to know that there's going to be excited workers to take care of me when I can't take care of myself anymore. That's what worries me.
Recently, to some skepticism by many, you closed a number of beds in one of your hospital. And the thought process was this is going to make things 10 times worse. We're busting at the seams as we are, but yet you're actually seeing a reduction in your boarding hours in the emergency department in this hospital after you close beds and starting to see a reduction in length of stay, which again seems counterintuitive. I'd love to hear more about this.
Yeah. So actually, I'm so glad you asked because this is one of my favorite things to talk about. Because I was a relatively newcomer to our big tertiary care hospital that is the solution for everybody and everything. And so here I come with this idea to do just what you said, to close some capacity. And I know people thought I was nuts, but this is where never forgetting from which you came and remembering your lessons learned. I have learned from the very beginning that progressive care beds and observation beds were the most overutilized beds in every setting. If I give physicians 100 progressive care beds, they'll put a patient in there. But if I start to limit that capacity, they will become very judicious with the patients that they select to go in there. Because when you're working in a busy emergency room and Sally Smith comes in with vague chest pain and you work up Sally and her enzymes are negative and her EKG looks okay. It's much easier to throw her into an available observation bed or an available progressive care bed and watch her overnight. Just maybe do a stress test. That's a path of least resistance instead of discharging her and setting her up with a cardiology visit the next day. So it's easier for the team to take that path of least resistance. But then what I also know for experience is that patient doesn't just stay for 12 or 24 hours. They get lost in the system and they're there for 48, 72 hours or even longer because they're not the sickest of the sick anymore. And suddenly your your hospital becomes very congested. The number of patients that the hospitalist are following and the case manager are following is very overwhelming. So what I knew is that I could safely compress some of those PCU beds and those observation beds without really harming patient access because we still have the service, we just had a little less of it. I also knew that was just one tactic that would enable many other tactics to happen. So, in other words, if I was able to compress some of those beds, I would be able to free up hospitalists to be redeployed to the emergency room to watch the boarders and make sure that they were moving through the system quickly and had priority. I would be able to zone case managers, staff them on areas that were slower moving throughout the hospital so they would get to know the patients and be able to speed up the process. You hit the nail on the head. When we started this process, we had 60 some boarders in the emergency department and people were telling me, this will never work. We're going to have 80 to 90 boarders in the ED. We can't handle it. I will never forget the second week, we had under 10 boarders in the emergency department. And now we've hit like our stride between 15 and 20. Sometimes in the beginning of the week, we might pop up in the 40s. But what I've noticed is they don't tolerate the 40s very long and they got to come back down and get down around 20. The whole system, compressing some of those beds just enabled a whole other variety of other tactics to happen that improved the throughput. This past month, we actually saw a higher census and did a higher rate of admissions than in previous months, but our length of stay and average daily census is at least 20 patients less than what it was the month before. People are just scratching their heads saying it's working. But what's exciting for me is it wasn't just the 33 beds. That was just an enabling tactic for all the other solutions. And they're doing it, refining their tactics, and they're finding more and more things. And they're getting excited by the success and finding other opportunities. Now they want to do a better job with observation patients. Now they're looking at that and saying, I think we have too many patients in observation. We could be more judicious with that. How do we manage that more aggressively? So lots of doors opening by that one tactic.
This change took a lot of guts on your part, Leslie. What leadership strategies did you employ for this to be so successful?
How was I brave enough to just do it, even despite opposition? I went back to we're going to try it. We're going to give it a try. Trust me, I've done it before. It'll enable other things. I know you're scared, but I think we can make it work. And I want your feedback. I want your collaboration. I went to the physicians. Fortunately, one of the ED physicians I knew, and he knew that it was a tactic that would work because we did it together in another organization. But again, I don't think the 33 beds was the thing. It was just the enabling step to allow the other tactics to work. And that's where I think the power has been. And now it's just proving to them that they were, in fact, overutilizing the progressive care beds and the observation bed.
I hear you saying is the rubber band was stretched too thin and it was so tight, there was no ability to be operationally efficient. And
Oh,
by loosening that up a little bit, it allows you to actually be more efficient.
it does. It really does. I know it sounds counterintuitive, but it just works.
We do the same thing in the emergency departments a lot where we look at a fast track and they've got 12 fast track beds, but their patients are just sitting there. And so you cut the number in half to 6 or 4 beds, and all of a sudden you're moving through those patients more efficiently because it's the same number of providers, whether it be one, APP or two or an APP and a physician. If you cut down the number of beds, you can burn and churn, so to speak.
That's right. That's
Yeah.
exactly right.
Let's return back to a topic from our previous episode and focus on developing emerging leaders. You talked in that episode about your development programs from the employer perspective, but I'm curious, what do you believe are key attributes an aspiring nurse leader themselves should focus on?
I just would reinforce that you don't need to know all the answers. And it's okay to be a little vulnerable and say you don't. It doesn't make you a lesser leader. It's actually makes you a wiser leader that isn't afraid to say, you know what, I don't quite know that answer, but we're going to figure it out together. We're going to find out. And it's okay to try something. And then if it doesn't work, not see that as a failure, but see it as a pivot, as an opportunity to make some progress. And now, if that didn't work, okay, good. That doesn't work. Let's try something else. It just amazes me the number of leaders that think they have to have all the answers. Trust me, staff isn't looking for you to have all the answers. As a matter of fact, when you do, they're cynical and skeptical about that. They're more anxious to hear from a leader that is willing to engage with them and say, you know what, I'm not sure, or I don't know, but we're going to figure it out and we're going to figure it out together. So I never want to miss an opportunity when I have a platform to really say authentic leadership is really about leaders that are willing to be transparent, vulnerable, and collaborative. Those are the things that really make a difference. And don't remove yourself so far from where the real work happens, and never forget from whence you came. Remember, you were there. You were that frontline person that you're now making decisions for. And how would you have wanted your leader to, to advocate on your behalf? Do you want a leader that connects with you on the front line, or do you want a leader that sits in their office and thinks they know all the answers? I really don't think you want the latter.
Awesome. Any closing thoughts?
Even though it's difficult to be in healthcare right now, I think the opportunity for us is amazing. We have a chance to really write the book on what it's like post COVID for healthcare. And I want to be one of those people that worries about the staff, that is a person that helps reignite them and help find their passion. And at the end of the day, if I'm able to do that, I'm going to feel really great about what my contribution was.
Leslie, thank you so much for taking the time today to continue our discussion. There's a lot to learn in the previous episode about your leadership journey, and today I really appreciated hearing about creating a sense of urgency and in an environment created and centered on a willingness to try in your performance improvement endeavors.
Thank you. It was my pleasure. And thanks for asking me.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.